Mm.
All right. So welcome today's Lunch and Learn. I'm really excited, John and I, to host Neer, Patel, and Angel Saucedo from Virtuous Benefits. They are going to be talking to us today and kind of really peeling back the layers on why your renewals always go up, why healthcare costs are crazy, and what your broker is really not telling you. And so I think this will be a really informative session. We're really going to start talking about how to create an employer-driven health care plan that really incorporates the benefits of direct primary care to reduce your cost, as opposed to just a plan-driven health benefit. So I'm excited to learn from you guys today. This is health care coverage is very complex and I think overwhelming to lay people. And I appreciate in our previous conversations how simple you both made it. So I'm looking forward to sharing that knowledge with some of our mission direct primary care friends and allies. So welcome. And
Thank you for having us.
Thank you.
You want me to introduce myself?
Yeah, I forgot to introduce John.
So I'm Dr. John Holgren. I'm a family physician, and I'm the doctor for our practice at Mission Direct Primary Care.
So, welcome, guys. I'm glad you have the time today. And I will just turn it over. And I feel like we can, turn it over to you guys, and then I'll keep a note of questions because I kind of like to be the voice of the people, and translate for the not ask the questions that the non-experts have, and we'll wrap up with some questions, and that's the plan for today. So thank you.
Yeah, thanks.
Did you want us to give a quick intro of ourselves, or just go through the questions?
Please. Yeah, the floor is yours.
Neer, do you want to go first?
Sure. So I'm Neer Patel. I do a couple of things. I'm head of operations of our direct primary care practice in Austin, Texas, called Direct Med DPC. And then I also am owner of Virtuous Benefits, which is a health insurance brokerage where we teach employers a strategy on how to take control of their ever-rising healthcare costs.
So I'm Angel Saucedo. I am a benefits consultant, and I've been doing this for about 10 years. And for the first part of my career, I like to say I was contributing to the healthcare rise problem because I didn't know any better, and you're taught what you're taught. But towards the last few years, I'm glad I discovered this strategy in Neer, and so now we're re-educating everybody on how to lower their costs but get better care.
Yeah, great.
I think that's great. It's so great to meet somebody that from the insurance industry that gets it and is trying to be part of the true solution. So thank you for that mindset.
Of course.
So
if you want to start with the first question, and then we can kind of go from there.
So yeah, why is health insurance so expensive?
So great question, and I'm always the complaint department, I feel, because I'm the one bringing the renewal. And so there's a couple factors that I always point out. The first factor that I always say is you're typically overpaying for the services that you're getting. So when it comes to labs, imaging, even the physician visits themselves, especially when it comes to hospitalization, what the actual cost of that service, when you run it through insurance, it is 10 or 20 times more. And so as a consumer, you kind of have no say in the matter, and you're at the mercy of the health insurance. So that's the first, you're overpaying for services. The second is actually that most individuals, and I will definitely say it's males, wait until something is very wrong or something really hurts before they go get care. And so that causes some problems in itself, because the longer you wait to get something done, typically the more expensive it is to treat. And so that reactive approach to your healthcare really contributes to it costing you so much money. So those are, I would say, the two main reasons. The third that I would also add is under the Affordable Care Act, the insurance company actually has the ability to raise your rate up to 20% every year, as long as they can show that they've paid more in claims. So think about that for a second. If I, as an insurance company, can raise your premiums as long as I show an increase in claims, is there an incentive for me to lower your cost, right? or lower claims. There really isn't. And so that's the abilities that insurance companies have. So when you see claims going up, one of the things that we have found is that there's a lot of either fraud or even misbilling, incorrect billing. I mean, when you think of just the sheer volume of all the claims that are going through, very easy to make mistakes. And so the insurance company could do something about it, but more times than not, they realize, well, if we can pay more in claims, we'll get more on premium. There's no incentive there. So those are a couple factors that I would say cause your increase to go up every year.
Yeah. And it's a really perversely incentivized system. You know, we're incentivized to use the system more, not less, and make costs go up. So what is these terms I think are confusing to a lot of people for employee benefits. So fully insured plan and level funded plans, they're also called self-funded plans and partial self-funded plans.
I don't know about partial self-funded.
That's not the right word, but yeah. So what is the difference? Yeah, what is the difference between those, and what do we need to know about that?
So the fully insured is what everybody is now kind of used to for the past 20, 30 years, if not more. The idea is that you pay a premium, that you have no way of negotiating if that premium goes up or down. Typically, the insurance company doesn't give you any kind of data on why either it's going up or it's staying the same, or just utilization in general. Yeah, because obviously when you pay for something, you'd like to know if somebody in the group is utilizing it. Maybe not down to the level of who is and what happened, but overall, you'd like to get some sort of reporting. And under the healthcare law, a fully insured plan, the insurance company cannot ask any health questions. And so at the beginning, that sounds great. You know, I don't want the insurance company asking me any questions. I just want to pay for my insurance. But because they can't know if you're either terminally ill or in great shape, what they do is they spread out that risk over to everybody. And so they base it on your age, your zip code, and even your gender. And typically they're overcharging because, again, they don't know what they're getting into. And that's one of the reasons that health insurance is going up as well. But a fully insured plan, you ask no health questions, you have no say in negotiating, and when your renewal comes, you have no data. So this is typically your Blue Cross Blue Shield, United Healthcare, Humana. Those type of plans are fully insured. And again, it goes back to what I just mentioned. Now, the difference of that and a level funded, which is essentially a self-funded option for small employers. Most employers that are a couple hundred plus are using some sort of self-funded. But for the small employer, they either think they can't afford it or they don't have the savings or the capital to pay for those claims. So level funded was created, self-funded basically for small employers. And essentially what it is your health insurance provider now actually asks health questions. Your rate is now based on the health of your company, which is powerful because I've heard companies and some of our clients, they are older, but they're healthy. And so they don't want the fully insured option that penalizes them because there's no health questions answered. So level funded, you get those health questions. They actually tell you how your money is being broken up. So when you pay your premium every month, they tell you, this is how much it's going to your claims. This is how much we're keeping for administration. This is how much we're keeping for what we call a stop loss insurance, which is essentially a secondary insurance built in that takes over large claims. So anytime a claim goes over $15,000 or $30,000, included in that plan is that secondary insurance that takes over, which eliminates all risk to the employer. So the employer is never going to be asked, hey, somebody got cancer, unfortunately it was a couple $1 million. You're going to have to pay for some of that. That's completely eliminated. And even for the employee, if they also have a high claim, they're only capped at their deductible or out-of-pocket max. The third and probably most powerful thing about a level funded plan that honestly people don't believe me, especially employers when I say it, is you have a potential to get a refund from your health insurance carrier. So I asked the question, has the insurance company ever given you any money back, even on the years you didn't use it? And the answer is I've never seen a dime back. So level funded, for those years that you had low claims, insurance company actually gives you money back. So you can either reinvest it in your business or reinvest it into your benefits plan.
And then does that, do those good, healthy years affect your underwriting for future years with that carrier?
So typically they're looking at it from a 12-month window, right? So anything that happened the previous 12 months, they're going to gauge that for the next 12 months, especially if on the renewal they see that there hasn't been a lot of change in your demographics. Essentially the same employees are still there. If you had good years, they're going to give you a good renewal on top of what your surplus or your refund is going to be. But if you had a bad year, then you may see an increase, a slight increase on your insurance. But again, all the money that you got to keep the previous years, you're already saving that year over year.
Right. What other types of benefits can a level funded plan have?
So again, it gives you the driving seat now of premiums and utilization. And so again, in the fully insured model, you have no say, you have no power or effect to lower your rate or try to negotiate. So a level funded, all the benefits that I just mentioned, it really puts the employer now in the driver's seat of controlling that cost.
Okay.
Neer, any thoughts on any of that?
Yeah, so direct primary care is, I think, one of the following questions that comes up, and I kind of wanted to add to that once we get to the direct primary care part of it.
So how can I have control if I have a refund? Now we're getting direct primary care.
Very good, very good. So I tell employers, if all you had was this level funded option, and that's the only thing you offer to your employees, you'd basically be at the mercy of high claims. So what I kind of call a ticking time bomb. Maybe 1 year everybody's healthy, but if you don't have anything built into your plan that either helps them get care or make care a little more affordable, then you're just waiting for somebody to get seriously sick. And like I said at the beginning, a lot of times people wait. Maybe they were sick, but they wait. And so again, you're just waiting around for that big claim to hit. So the important thing that you need to do to control it is incorporate direct primary care. That's where I'll let Neer kind of take over and explain what that is.
Sure, yeah.
Yeah, elaborate on how direct primary care is such an important piece of this puzzle.
Yep. So we learned a little bit about what level funded health insurance is. And the key really that I believe to the success of making the level funded insurance strategy work is coupling it with a direct primary care practice. That direct primary care practice is going to handle 80 to 90% of all of your employees' healthcare needs. They're going to be sort of the front lines, the first point of contact that the employees are always going to reach out to when they have a non-life-threatening emergency situation, which is 80 to 90% of most people's health concerns. And so what essentially we're doing is the direct primary care doctor is stewarding really the money for the employer and the employee, as well as taking amazing care of the employee. So, and nothing that happens in the direct primary care office is going to hit the insurance plan. And so what we're trying to do is essentially steer unnecessary claims away from the insurance plan. So we have the insurance plan kind of hanging around in the background for the bad, super expensive, unexpected things that might happen. And that's really what we're trying to teach individuals and employers in this country, is that we need to change our thinking. We need to think about health insurance like we think about every other insurance policy we have. Currently, for auto insurance, homeowners insurance, and all the other insurance policies we have, we don't file a claim for every single thing we need. But we do that in health insurance because that's just the way that we've been trained for the last 40 years. But that I also feel is part of the problem of why the healthcare system is so broken. So what we're trying to do is help employers and employees understand that we need to think about health insurance for the bad things and the expensive things, and then we need to work with our direct primary care doctor for pretty much everything else. So when we're steering those claims away from the health plan through the direct primary care practice, the claims, when you look at the 12-month period of being in this strategy, the claims typically are dramatically reduced. ER visits are dramatically reduced, hospitalizations are dramatically reduced. And that is really how we get this strategy to work. At that point, you've got low claims, which doesn't give the insurance company any leverage to increase your rate proportionally the following year. So you really get to the point where you have flat renewal rates, or you can even get decreased renewal rates. And then there is a claims fund that is part of the couple of buckets that Angel explained on the level funded side, where a good portion of the premium every month is going into that claims fund. About 50% of the premium actually is going into the claims fund every month for each employee. And when that claims fund money isn't used for claims, the carrier is required to refund it back to the employer. So when we're working with the direct primary care doctor for 80 to 90% of our healthcare needs, the likelihood that there's going to be a large surplus in that claims fund becomes very high. And so that's another powerful aspect of this strategy. When we couple level funded health insurance with a direct primary care practice, we really have the best of all worlds to set ourselves up as an employer to then start, have a long-term strategy to take control of our healthcare costs and keep them from rising, 10 to 30% year over year. And then we also have this claims fund surplus that's powerful that, we have the potential of getting a refund for and then reinvesting in our business and, in salaries and benefits for employees, et cetera.
I think it's a really important part of the plan that's sometimes missed. I've heard stories from business owners that have gone level funded but didn't have that piece. And so then the claims on their claims fund were driven higher because their people were accessing care and typically insurance-based practices through, the mid-level, entry-level, which drives, more imaging, more tests, more trips to specialists, because it's all designed for that flow of revenue. And it just, they didn't see the savings that they were sold. And so I think it's a really, partnering it with the direct primary care is really kind of the key to longer term success and keeping people healthy and protecting that. So I think it's great that you guys are taking the time to educate people on that.
Absolutely.
I couldn't agree more. I wish I could take you all around when we meet with business folks here in Omaha.
Because it's frequently kind of a missed part of the puzzle. They think they can still be accessing care in insurance-based hospital systems.
Right. The other thing I just want to reiterate is that a lot of employers will just kind of see the picture that the direct primary care is an additional cost. Right. It is an additional cost. However, it is your investment in the success of this strategy and in really reducing your healthcare costs anywhere from 30 to 60%. It's your investment in doing that. Without the direct primary care practice, the likelihood of getting having a surplus in the claims fund becomes very low. The likelihood of reducing your claims becomes very low. So then you get right back into the same situation you were in where your healthcare costs are ever rising year over year. The direct primary care practice is stewarding your money as the employer, and you paying for the direct primary care, 100% of it is what we recommend to employers. Pay 100% for all of your employees, because that is incentivizing them to use that direct primary care practice. We can't force anybody to go to a particular facility for healthcare, but we can incentivize them to do so. So paying for 100% of the direct primary care membership incentivizes the employees to make the right choice, which then allows you to, get the greatest chance of success of reducing your healthcare costs and physically increasing the health of your employees.
Great points. So how is this arrangement different from something like another alternative to fully insured plans like a health share?
So a health share is very different. One of the things that I always point out between a health share and any kind of insurance-based plan, the health share legally doesn't have to pay for any claims because they're not insurance. They're not regulated. And so even though they'll never tell you, oh, we won't pay a claim, we've always paid claims, that's why we're still in business. If you just look at some news stories across the country, a lot of them are being sued because somebody had a claim that wasn't paid, and the appeal process isn't very strong to where, again, they're just looking for a way not to pay you at that point. So it's very important that you understand that there is no financial, legal ramification to the health share for them not to pay a claim. And typically, here in the area, I've spoken to a few, and when it comes down to some of these hard questions, they always say, well, it's not for everybody. And the reason behind it is a health share arrangement is designed for an individual who is really not going to get care through it. Just someone that's healthy. It's really more accident based, to where if somebody breaks a leg or gets hurt, they can go to a doctor and then they'll try to negotiate a price behind the scenes. But it is not really designed for somebody that is having an illness, an ongoing illness, or that has a large claim. And again, they may or may not tell you that. The other part of a health share arrangement, when you start looking at some of the details for an employer, typically they want you to set up a separate bank account so they can draft claims from it. And if you ever cancel your health share arrangement from a company standpoint, they will actually ask you to keep that bank account open for up to a year. So again, if there's any lingering claims, they can pay it. So those are probably the two biggest differences between a health share arrangement and any kind of insurance-related arrangement.
This is kind of a semi-related question. For the level of fund, for the insured portion of the level funded plan, does that utilize networks, or is that just insurance, like hospital networks, like a traditional insurance plan? I've never heard that about. So
there's two options, and it depends on the employer size. So under 25 employees, we have to kind of lease out a network from somebody, because you're not big enough to try to, basically build the plan that we're talking about. So it's kind of a baby step towards what essentially we're trying to get you at. Essentially what we're trying to get you at is a no network. You're building your own health plan. You're contracting directly with facilities, paying them faster so you can get lower, and there's a negotiating standpoint there. But under 25 employees, we typically do use a network-based insurance carrier, and that allows us two things. Number one, it allows everybody to feel a little bit comfortable, because from a small employee standpoint, when you're incorporating all this, they think, okay, I'm going to a doctor that I'm not used to, changing the way I look at insurance, and now I don't get a network that I'm typically used to. And so that's where we incorporate that. Gives them the ease of mind, kind of the best of both worlds. So yes, on a smaller employer, under 25 employees, there is a network-based insurance carrier built in.
Okay, great, thank you for that. So why is this not a typically common arrangement that brokers talk about? The level funded PC.
So there's two things that I would say. So as you can see, I'm fairly young. I'm 33 years old. Most brokers are either 55, 60, a lot older. They've been doing
really
it for
20,
30 years.
It's a good thing you said 55 and not 51.
Yeah, 51, I would take.
And so they're kind of set in how they've been selling it for so many years. They actually have a lot of doubt of this arrangement, specifically on the doctors. They don't know if they're going to be in business. And so they typically push the insurance model. Other part of that is how compensation works. So most brokers are paid based on how the premium is. So the higher the premium, the more commission they receive. So now when you're talking about lowering premium, in their minds, all they're thinking is that's a pay cut. That's, especially if they've been doing it for so long, that's a big chunk of their revenue being cut off. And in that revenue conversation, the other thing that happens, at least in our arrangement, there is no compensation from the DPC practice to myself. So if I bring Neer as many patients as I can, I'm not getting a dime for any of those patients on the membership side. And so that's where brokers have a lot of, they kind of say, well, if I'm bringing a doctor patients, I want to get compensated for that. And so they doubt it. It affects their compensation. And those are the two main reasons you don't see a lot of brokers talking.
Interesting.
Can I jump in with one? Are there legal reasons that can't happen, or splitting, but I don't know if that really qualifies.
So when it comes to a doctor's office, a physician office, I, as a non-physician, I don't have a license, I cannot get any compensation for the patients, whether it be a membership or however that arrangement may be. But as a non-physician, I can't get compensation for that. Sometimes what I have seen is doctors try to give what they call a marketing fee to a broker. And so you kind of get into some gray area when you're talking about if I'm bringing you patients and I'm being paid back a marketing fee for that, it still has a commission type of revenue feel to it. And so I kind of advise against it, but that's probably the legal ramifications. Legally, I cannot get any kind of commission or fee for bringing in doctor patients.
So if you could wave a wand, why, how would you fix this? Like, since this is what we all agree is a better option, is to have someone who's compensated only to take care of patients and not generate revenue for a hospital system, who then for, you know, the 90% of the day-to-day wellness care, and then have an insured product for catastrophic events. We identified why it's perversely incentive with, you know, premium increases only being driven through claims, and profits for companies and, you know, increases in pay for brokers only being driven by premium increases. How would you, what would be the ideal system that you would see?
So ideally what we're trying to get, and again, I'll mention that this is for employers 25 employees and greater. What we do is we would build your own health plan, much like you would build your own house. Right now, if you're on a fully insured model, you're essentially renting a network from a health insurance carrier. So you're renting, you're not buying. And so again, the incentive from building your own, you can put in all the pieces that you want, from medication to doctors to hospitals. And essentially what you're doing in this model is you're still giving everybody access to care. We would argue you're giving them better care, but you're having more buying power in the matter. So now you're going to a hospital or to your employee and say, look, let's just say you need a knee surgery. These are the prices that every hospital charges. We're gonna incentivize you to go to the higher quality, low cost facility. And the reason they're higher quality is because they do this all the time. So we give employees the data, how many surgeries that physician or that hospital system has performed, what the outcomes have been, because as a consumer, you want that data. Just like when you're shopping for a car or clothing or a house, you want to know what's the difference between each one and which one is better. So we're giving employees that data. And now we're saying, look, if you go to the higher performance, low cost facility, the plan that we've built is going to 100% pay for that. You don't have a deductible, you don't have an out-of-pocket cost, you don't have a copay. It is 100% paid for. If you choose to go anywhere else that doesn't have that data behind it, doesn't want to negotiate with us, simply wants to overcharge you, then you now have a financial responsibility, $5,000, $6,000, basically as high as we can go based on the plan, because we want every employee to be held accountable for their healthcare options. One of the things that employers don't realize is when you give an employee a health insurance card and you try to keep that deductible low, which everybody likes, $1,000 deductible, $2,000, you're giving them an unlimited credit card. So after that $1,000, after that $2,000, they can go wherever they want, no questions asked, there's no limit. So from an employee standpoint, there's no accountability for if I pay or get a surgery done somewhere else, I'm not paying for it, somebody else is paying for it. So our arrangement, we're giving you better care, but we're holding each employee accountable. Just like an employer, you know, when their employee comes to them and says, hey, I need a new vehicle to get to work, the employer doesn't say, well, go find yourself a Mercedes, we'll pay for it. They say, look, what we're paying you, you're gonna get what you can afford, or, you know, figure out an arrangement. But typically, every employee is financially responsible for their decisions in every other aspect of that business. If an employee travels, they may not get to fly first class and stay at a 5-star hotel, but they do get, you know, reasonable accommodations. So again, we're trying to give that same mentality to healthcare. And so that model allows us to do that.
Yeah. I think it all speaks to that there's a joint responsibility between employer and employee, and the health system to you know, work together to keep costs reasonable and efficient. So how can a company go about getting a quote for this type of plan, and what questions should they ask, and kind of what points should they be aware of?
So they could definitely reach out to either one of us. They could talk to their current advisor and basically ask, how do I get this started? And it's going to happen with, you know, it depends on what stage you want to do. So a lot of employers say, I just want a number. Just give me a number on how much ballpark this would cost. So we need some preliminary demographic information. You know, we call it a census. just to give you that ballpark. If you want a more clear-cut answer to where if you were to start, how much exactly is this going to cost? We're either going to ask for some health questionnaires to be filled out, or if you have any kind of claims data for the past couple of years, we're going to need that as well. So there is a little bit of a process to get a full number, but once we get that firm number, we say, look, if you were to implement this, here's how all the parts work, here's how much it would cost and how much you would save, and how much at the end of the term year you would possibly get back.
What type of timeline does that take place on?
Yeah.
You know, for an employer that's thinking about investigating new options, how far back from their current renewal date should they start to really get serious about looking?
At least give us 60 days just to make sure we have everything. If an employer just is on top of it, you know, sometimes we give an employer questionnaires and every single one of their employees fills it out within a couple of days, then 30 days we could do it. So, but I would say a fair number is 60 days because obviously they got other things going on. 60 days before the renewal, we can start working.
Yeah, the last thing anybody wants to be under is being under the gun when there's a renewal coming up, especially when, you know, you're looking at exploring a new strategy, which is, you know, this is very different. It's a leap. It takes a really good benefits advisor and a courageous employer to do this. So we definitely don't want anyone to be under the gun. 60 days, even 90 days, if they're able to give it to us, would be preferred.
Okay. And is there any type of employee group that this might not be a great fit for?
What I typically say is everybody that's working is typically healthy. And so you're going to get a favorable rate, but you know, the underwriting aspect of it, sometimes we find out, you know, somebody has serious illnesses going on, or, you know, a couple of years back they had a heart attack or something. And so until we get down to, you know, the actual claims data, we won't know that. But before you move forward, we'll always say, look, turns out your claims have been high. A couple people are real sick. Maybe the insurance option isn't right now ready for you, but definitely look at the direct primary care to at least start helping those individuals that maybe are getting care that's more claims driven than actually getting them better. And so that's something that people always don't think about. They think, I'm going to the doctor or the hospital. Their goal is to take care of me. And we always say, well, because of the business side of it, they're incentivized to kind of keep you coming back. So maybe try going to a doctor who's incentivized to keep you healthy, and then we can relook at it. Yeah.
One of the common concerns that I've heard is for companies that have multiple locations in different metro or not metro areas here in Nebraska, and with the direct primary care element. And I think that that's one thing, because we're all independent practices, that can be a concern, because you generally start this conversation with a local to you direct primary care practice. But I want to point out that that's how you and I got connected, is that you were looking for a Texas-based company that had some employees up here in Nebraska. And that we are, although we're independent, we are affiliated in our philosophy and in the focus of our practice and the foundations of how we operate. And so you can you can kind of build an informal network for each employer of like-minded practices, because there's over 1,000 direct primary care practices in the, operating right now.
Right. Yeah, just to add to that. Yeah. So as we're all well aware, there's, I think there's now close to 2,000 DPC practices on the direct primary care mapper. And so that's exactly what we do. So if we're working with a company that's local, that has employees scattered throughout that particular town and or scattered throughout the country, we simply get in touch with our colleagues that are doing direct primary care and bring them in to, in their respective areas, and link them up with the employees that are in those respective areas to be brought into a plan like this. So that's something that we're doing currently, and we don't really, see any issues with it. The majority of this country is covered with DPC, I would say, at this point. And, and if not, there's usually one, within 30 to 60 minutes away, which, as we know, we can still take care of patients, very well with telemedicine. And, the frequency of them having to come into the office is low, especially if they're far away, or can be. I know in our practice, we're taking care of patients all across the country, as well as in Houston, Dallas, San Antonio. These are, places that are 3-4 hours away. So,
yeah.
And I just want to add, DPCs have been very easy to work with because they're so passionate about what they do. They are wanting to help the movement grow. So they want as many people as they can utilizing this model. So when we reach out to DPCs across state lines and we say, look, this is the price that we've kind of negotiated, we have found that typically it's a range, anywhere between $50 to $100 most DPCs have. So we try to find a good middle ground and say, look, will you accept this rate for everybody? Knowing that if employees at your location start using it, they're going to tell their friends and family, how could we get this? Our company's paying for it. And your own practice not only is going to grow, but you're going to be able to help more patients. So I've been very impressed working with DPCs just across the country.
Don't hesitate to reach out to us.
Will do.
Well, thank you guys. Is there anything else that, in closing, that you think is real important for people to know as they start to research this level funded option for their smaller businesses?
The one thing that I always want to mention, because it comes up a lot, is an employee will say, can I keep my doctor in this arrangement? And so the question that I ask them is, does your doctor want to keep you? And so they say, what do you mean by that? And I said, well, if you look at the financial amount that you're compensating this physician based on your insurance and based on your copays or out of pocket, how much is that relationship costing you? And typically it's anywhere between $6,000 to $8,000 a year, even though you typically only see that doctor once or twice. So I tell them, if you were to go back to your doctor and say, look, I'm going out of the insurance model, how much would you charge me per visit? If they're willing to work with you, especially if you've been a patient for years, then they're going to give you a fair number. But if they're realizing, no, I like the insurance model, I like $500, $1,000 per visit because that's what I charge the insurance company, you may start seeing your doctor in a different light. And it's nothing against them. They're just used to a different financial compensation. So what I always ask is, ask your doctor if they're willing to keep you, or if they're willing to try a model like this, and then you'll get a better answer then, or you may not want to keep your doctor at that.
That is such a smart way to frame it.
Yeah, it is.
That is a really...
Seriously, I may see if I can get you guys to come up and go around.
Because you're right. I mean, that's the thing is, and that's the most common, one of the more common objections that I get is that people don't want to change their doctor. I typically ask them, when was the last time you actually saw your doctor and how long did you see them for? And how much did it cost you? But that's a really good point, is that if your doctor wants to continue that relationship, what is it going to cost you? So thank you for that.
Yeah.
Neer, do you have any kind of last closing thoughts or insights?
I think just generally speaking, employers, I think, are disconnected from this particular expense within their companies from what I've seen in my experience now in insurance over the last couple of years. I feel like the employers are disconnected by design because they feel they don't want to deal with it. It's complex, it's confusing, it's expensive. It makes my head spin. So they empower their HR people or someone else to take control of it. And generally what I've seen in that situation is that these folks aren't typically forward thinking. They have to do some work to implement a strategy like this. We help us, the third-party administrator, everybody that's involved in this, we help do the majority of the work. So, there's not that much work that the company has to do, but as far as work, meaning educating, facilitating, administering, there is some work that has to be done. So, these HR folks are typically trying to shoot this down because it's different. And so, I try to stress to employers as much as possible, this is your money. This is an astronomical amount of your money that's being spent on health insurance as a benefit for your employees because you genuinely care about them and you want them to be healthy so that your business continues to remain healthy. And, you need to take a hard look at what's happening with your money. This is one of the most expensive line items on every business's P&L. And the only way that we're going to start changing the thinking and fix this broken healthcare system is by starting to look at what's happening with the dollars, and what's happening with the care in relation to what's happening with the dollars. And right now the dollars are astronomically skyrocketing and the care is astronomically declining. So we need to change that. And this strategy is part of the solution of helping change that. So, before just, thinking about every single objection you can ever think of with this strategy, I just encourage every employer to really take a hard look at it and be involved as the owner. If it's, whoever's money it is, you need to be involved in the process to understand it, because we are genuinely doing this to try to help fix the broken healthcare system, to try to create more awareness about direct primary care throughout this country. Direct primary care is a very big part of the solution of the broken healthcare system. And we need to get direct primary care into as many employer-sponsored health plans across the country as we can. And this is the way, one of the ways that we're going to do it. So that's what I would leave everyone with is, let's be more savvy about where our money is going and how we're spending it on healthcare.
I think that's a great charge to leave everybody with, because I think you're exactly right. It's people don't want to deal with it and they feel so abused by how it's been implemented over the past decade that they're just prefer to cover their heads up. But it's time that we all lift our heads up and see how we can be part of the solution instead of waiting for someone to fix it for us.
Yeah, and the reality of the situation is the BUCAs, which is Blue Cross, United, Cigna, Aetna, Humana, are profiting hundreds of billions of dollars per year. So, it truly is insurer-billed healthcare right now, not employer-billed healthcare, and that's why we need to be diligent to start exploring the employer-billed healthcare side of things.
Yeah, couldn't agree more.
Great. Well, thank you guys so much for your time. Virtuous Benefits, I'll make sure to include your contact information when I forward this out to the folks that registered and asked for the recording. And I really appreciate it. It was very, very informative, and you made it very easy to understand, a very complex thing, very easy to understand, and I appreciate that.
Yeah, I do too.
Thanks for having us.
Yeah, this discussion is going to make it easier for me to explain things going forward, because this is a really good job. Thanks. I really appreciate you taking the time to do this with us.
Thanks so much for having us. And yeah, please feel free to reach out if we can help in any way.